Okay, we are live and welcome to another episode of Machine Medicine's Neuromodulation Today and Tomorrow podcast. And we are very pleased to have Alex Rogers here today. And Alex, perhaps you'd be so kind as to give us a brief introduction as to yourself and your background and what you're up to now.
Yeah, thanks for having me today. My name is Alex Rogers, and I'm a urologist by training. I have a big passion for helping women with incontinence issues, considering the fact that many women suffer from this, over 60%, and over 50% of women have urge urinary incontinence. Yet roughly 80% are untreated with our current therapy modalities. I pursued being part of the Ecoin pivotal trial, a unique neuromodulation device. And now I am part of their launch for procedural training to safely train physicians to implant this form factor down in the leg above the tibial nerve.
Fantastic. And let's just before we get into the sort of nitty gritty of the sort of particular, let's just understand the dimensions of this problem. You said something about it. So did you say 60% of women? Is that lifetime prevalence of incontinence?
There's a great update in a paper that was published in 2022 in FPMRS Journal. And they went back and looked at all the data, and they actually found that the incidence of incontinence is greatly increasing in women, where literally over 60% of women have some form of incontinence, whether it's stress incontinence, urge incontinence, mixed incontinence, a combination of the both. And so strikingly, between pure urge incontinence, where you're rushing to the bathroom and cannot make it in time, in addition to what we call mixed incontinence, where you have both stress incontinence, where you're on a trampoline jumping and you leak, or once again, you have that rushing sensation of, I cannot make it to the bathroom in time. That comes out to over 53% of women having urge incontinence where they leak.
Okay, and maybe just for the purposes of sort of completeness, you could give us a quick sort of anatomical or whatever you would say why is it that this is a problem that affects women so overwhelmingly?
Yeah, well, it's certainly something that is multifactorial based on age. So as we age, the nerves that are signaling for the bladder to calm down, that signal becomes disrupted. And so women, they don't get the signal that they need. So therefore, when they feel the need to go to the restroom, they do not have the time to make it. And that leads to a lot of women suffering from this condition and not saying anything to a professional, or certainly in a delayed fashion, on average, like 3 years, 1 to 3 years, where they actually tell a professional they're really bothered by this. And when you do have this type of leakage, it can be incredibly bothersome and really impede quality of life and lead to a lot of social isolation, depression, anxiety. And then a lot of women, the awareness about therapy options stops at using incontinence products that are expensive, often not covered by insurance. Currently, baby diapers and adult incontinence products are like neck and neck for filling landfills. So from an environmental standpoint, we have a big problem on our hands. And we do not see the prevalence of this condition decreasing by any means, when we know that things like obesity make it worse, other medical comorbidities, diabetes, and that is only increasing, especially during the COVID pandemic, where people certainly didn't lose weight during the last 2 years.
No, I can vouch for that. Is childbearing another issue here that predominantly affects women, or?
That's kind of a misnomer. There are so many women that suffer from overactive bladder that never had delivered or had a vaginal delivery. I will say this: stress urinary incontinence, where the urethra is slightly incompetent. Yes, vaginal deliveries, childbirth is associated with that type of leakage.
Right. But this, the urge incontinence that you're describing, so it's primarily a sort of neurogenic phenomenon, as far as you're concerned, or as far as
it's a nerve condition. All these women come in and they say, I leak, and it's because I didn't do my Kegels. And a lot of the times, if you have moderate to severe overactive bladder, you can't Kegel your way into staying dry with this condition. So physiotherapy often is not as helpful as we would like for moderate to severe overactive bladder. I'm a huge fan of physical therapy for more mild overactive bladder or mild moderate stress incontinence or pelvic pain conditions. But yeah, it's certainly not overactive bladder equals I didn't do my Kegels, more of a muscle phenomenon.
Gotcha. So that's and that sort of is a rather nice segue into the focus of our discussion today, which is about neuromodulation as a therapeutic approach for this problem. So we've mentioned it's neurogenic, so it kind of makes sort of 1 and 1 equals 2 kind of logical sense. But what are there's I doubtless there's much more detail to it, like which nerve do you go for and what's the approach? So can you say a little bit about that, where the ideas came from, what the first attempts were at choosing this?
We've been using neuromodulation to mitigate, manage overactive bladder for decades. Sacral neuromodulation was FDA approved in the United States in 1997, and that involves a lead being tunneled precisely along the S3 sacral nerve or the S4 sacral nerve, and then creating a tunnel to a fatty pocket to put in IPG to power that stimulation to the sacral nerve. And for 2.5 decades, we've been using that form factor of the lead and the battery at the buttocks backside with under sedation or general anesthetic, often in a multi-phase approach where you do a testing period anywhere from 5 to 2 weeks, either with a temporary wire or a permanent surgical lead. And we test the patient and we see objectively, subjectively, if they have at least a 50% improvement in their symptoms, such as not just urge incontinence, but also frequency, fecal incontinence, urinary retention, all of this nerve misbehavior that leads to those issues. And we have found that if you are good at implanting these leads, yes, you have high efficacy with such a therapy. And then you go on to implant the patient with that permanent battery. And then these batteries have, this therapy has evolved over the last few years, where in 2019, a brand came out with a rechargeable device with the advantage of, by recharge, you could go from a 4 to 7 year battery life to up to a 15-year battery life. And then there are 2 brands out there that offer that type of therapy. But more recently, just in 2022, this month and this past month, both brands came out with a longer lasting primary cell battery with various external components to manage for the patient, whether it's a key fob remote or a receiver with a remote with multiple programs. But so that is a neuromodulation treatment we've been offering for decades. Conversely, we've always known that peripheral tibial nerve stimulation with a needle, what we call percutaneous tibial nerve stimulation, it's been around in the United States with approval insurance coverage for over 10 years. And what we found that if you place a needle in the office at the tibial nerve, and you turn up stimulation externally and you see toe flexion and patients feel it along their foot, you do 30-minute sessions. You do it once a week for 12 weeks. If the patient has a response, and typically that drop off in symptoms or improvement in symptoms happens at week 6 to 12, then we recommend the patient do it monthly. So it is a very attractive therapy in regards to there's really no side effects. But it is burdensome. It is time consuming. You have to park, you have to check in, you have to come in, you have to have the needle placed, you have the 30 minutes of stimulation. It doesn't necessarily happen immediately. In the United States, there are a lot of insurance barriers where they may view it as experimental, although there are phenomenal papers showing that there's absolutely an efficacy that's much greater than placebo sham. So we've had PTNS, but the traction of it has been variable based on numerous factors. And then finally, from a medical standpoint, our last third line that we use is Botox injections of the bladder. And what we do is woman gets in a pelvic exam position, we numb the bladder, we take a telescope, we put it in the bladder, and we do small injections with Botox. Highly effective. Sometimes women are hesitant to sign up for it because you do have to redo it every 6 months. The procedure can be viewed as not exactly modest. There can be discomfort. And lastly, we do have to counsel patients. There's a risk that it is so great at relaxing the bladder muscle, at paralyzing the bladder muscle, just as it will do in women's faces when we inject it into her face, that you cannot urinate afterwards. And you may have temporary retention, possibly requiring intermittent catheterizing until the Botox wears off. So sometimes that fear factor is tough for patients to digest. And often, even if they do try this injection, they don't keep follow-up. We see that 90% stop doing it by the 4th visit, 90%. So the adherence to it can be very low. But I've just kind of given you this breakdown of where neuromodulation is used for overactive bladder beyond medications. We have medication, relax the bladder, make it more capacious.
Let me back you up. That's a fantastic synopsis, thank you. But let me back you up just a little tiny bit, because many of our viewers will not be urologists or even clinicians for that matter. And let's say, so initially you were talking about how was it S3, that kind of the traditional target, and to my mind, as you know, having done sort of clinical school anatomy, but then become a physician and not done a hell of a lot of anatomy, it still kind of makes sense, right? Because this is where is this the source of the pudendal nerve, for example? Are these where these nerves that innervate the bladder and the surrounding anatomy are coming from? So it sort of makes sense, right? You're intervening between the spinal cord and the actual organ. But then you started talking about the tibial nerve. Now, how the hell did that ever come into anyone's? Because where are we down there? We're down at the bottom of the leg, right? In the around the shin.
Yeah, there's so much. It goes back to this beautiful blend of Eastern medicine, where there's so much literature out there where in Chinese medicine, they know that when you do peripheral acupuncture of nerves, there's so many medical indications that improve with that peripheral intermittent stimulation. And if you think about it, the tibial nerve runs upstream the leg, and then eventually it hooks into the pelvic plexus. So it is this highway from the peripheral bottom nerve all the way to the brain. And when we've done PT in patients and we get MRIs of their brain before and after treatment, we see that areas in the brain light up. So
are these sensory areas, or in the are these sensory areas in the sensory motor, in the sensory cortex, or right?
Frontal. Yeah, I'd have to. I'm not I'm more of a clinician, but I read every abstract that comes across my way. And they don't quite understand the phenomenon. And it's like signals they're looking at, but they absolutely see changes.
Gotcha. So it's having some kind of effect, and we don't know if it's sort of antidromic stimulation or actually this is some natural sensory pathway that's somehow modulating nerves up. I mean, actually a lot like the rest of neuromodulation, right? It works, but we've got no idea. Is it really? Is there a Chinese textbook, ancient Chinese medicine textbook that says you stimulate, sort of do acupuncture in the tibial sort of region for urgent continence?
Yeah, there's tons of acupuncture literature on bladder health, but there's a gentleman, Peng Li, out of UC Irvine, who spent his whole career looking at acupuncture points. And for example, like the median nerve here, if you intermittently stimulate it, you perhaps could help treat refractory hypertension.
Yeah, sure. Okay. Yeah. I mean, very interesting. Hypertension, another active area of neuromodulation, the development, absolutely.
Endless. Osteoarthritis, Parkinson's, all of it. Yeah.
So tell us about, so the tibial nerve has been sort of identified rather remarkably as a target for treating hyperactivity. And so tell us about, and you describe, overactive bladder. And then you described the sort of the initial approach, and you said that if it was done well by, I guess, a skilled surgeon, then it could actually be very effective. When you say very effective, are we talking cure, or are we talking like 80% reduction in urgent continence, or what are we talking?
Yeah, so I'll go to PTNS data, and the responder rate is about 2/3 is what I quote patients. You have a 2/3 chance of getting improvement. 1/3 of the time just won't help you. In the world of overactive bladder, it's hard to hit dry. our dry rates with the therapies, whether it's meds, sacral, Botox, I would say it's roughly between 20% to 1/3. So
Right.
it's hard to hit cure, but the average patient we're treating with this is 65. So
Right.
we are taking nerves that, for decades have been dysfunctional.
Yeah.
So it's difficult to make it the nerve of a 20-year-old, right? Just like
Yeah.
anything
Sure.
in medicine. It's hard to hit perfection, but
Yeah.
the more, I think neuromodulation has the highest therapy potential to get more women and men to dry.
Yeah. Absolutely.
Yeah.
Very interesting. And of course, you mentioned earlier that it has next to no side effects, so the efficacy is reasonably weak. Whereas the drugs that are typically used, what kind of side effects would people get with these? Would they be anti-muscarinic and that kind of thing?
Let's talk about drugs. So anticholinergics, our first one was approved in 1975, oxybutyn or diazepam. Very cheap, but ironic side effects of dry mouth, dry eyes, constipation. So all of those things potentiate overactive bladder. I got to go drink more water. Constipation makes overactive bladder worse. So those meds typically are stopped 80% of the time by 1 year. And this is a chronic condition. Right.
Yeah.
So the adherence to those meds is terrible. In about 2013, we got our first beta agonist, and they are much safer in regards to side effect profile. The first one we had does have a warning of increased blood pressure, which can be challenging in this older patient population that at least half often already have hypertension baseline. Most of those patients are already on 13 meds when they walk into you to see you as a clinician.
Yeah.
We made a little bit more headway where in the past year we had a second beta agonist get approval. It really has minimal side effects, occasionally headache. But the issue with beta agonists is access. They can be very expensive. They often require prior authorization. So in regards to medication share in prescribing, roughly 80% of patients get an anticholinergic and about 20% a beta agonist.
Wow.
And then when we look at them staying on it over the long haul, most stop by a year, whether it's due to intolerable side effects, cost, or they just don't work well enough. When you look at med trials, their efficacy over placebo, it's not always overly dramatic. So often a patient, you give them a sample, they come back and they say, well, it just didn't help me enough. And I do want to bring up one other point about anticholinergics. In 2021, the OGS, Urogynecologic Association, came out with a clinical statement saying that anticholinergics should not be prescribed to women over 70 due to the mounting association with cognitive risk, i.e. dementia, things like that. So I'm extremely hesitant as a clinician to offer those medications to patients because I wouldn't take them myself, having a family history of Alzheimer's. So I always counsel patients of that clinical statement, and rightfully so. Most of them say, well, don't put me on that. And I agree with that.
That's very interesting. Yeah. And makes total sense given that the only sort of approved treatment for Alzheimer's is a cholinergic agonist. Anyway, that's very, very interesting. And so tell us, you've been doing work recently, and in particular, this paper, a pivotal study of leadless tibial nerve stimulation with Ecoin. So what this technology that you've been deploying in this trial, what's novel about it? Why is it? What problems is it solving?
Sure.
What are the interesting elements of it?
Yeah. So as a clinician, I was incredibly frustrated that we weren't treating women with the current overactive bladder toolbox, as I call it. I was well-versed in counseling on it, yet I had that high drop-off, attrition, adherence that was poor. So my mentor from medical school, Dr. Scott McDermott, was part of the feasibility trial. The feasibility trial was in New Zealand and the United States. And I saw his explanation of the results from that feasibility trial. And I'd always believed that tibial implant had high potential. People talked about it for years, but knowing that from an appeal standpoint, patients said yes to PTNS or that tibial needle. I'm not scared of it. You have a nice staff. I'll come in and do it. I'll say yes to that. Conversely, I felt very well trained in sacral neuromodulation, which is an art. You have to know how to tunnel that nerve beautifully, beautifully, you have to surf the nerve. It has to surf the nerve. If you're not on the nerve, then you're not going to get the treatment that you want.
Right, yeah.
And you have to have patients that are willing to undergo kind of a complex multi-phase trial. It's kind of challenging to understand. You also have to have great rep support on the back end to manage nerve fatigue. You have to make sure they understand how to use the remote. So it's hard to get patients to say yes to that. And as physicians, we have a 3-month wait time for patients coming to see us. When they walk in the door, you want to hand them this menu and say, these are your options and what is appealing and what will you say yes to? Yeah. And I just found that patients driving 5 hours to see me, it was really challenging. And especially patients like that, they couldn't come to 12 weekly sessions. They weren't ready to say yes to what sacral was in regards to what you're signing up for. And Botox was kind of a middle ground of getting treatment for 6 months, but they still may say no to that. I already talked about the issues with medications of patients trying them or staying on them. So when I saw this indicator in the feasibility, I was not a big researcher. I was just a normal bread and butter community female urologist. I reached out and I said, I need that in my practice. So I became a site for the Ecoin trial. And things that I found unique about it, the feasibility trial certainly showed that it works. It had a 68% responder rate, meaning that they took patients that came, exclusion criteria was very generous. Naive surgeons learned briefly how to do this, and then they placed it on the tibial nerve. And it's not a surgery, it's a procedure. It's a small incision. A pocket is made that is made with a custom tool. So it's made the same way every time. And this coin is dropped in above the nerve. And I have a little dummy device. But what's unique about it compared to the form factor we've known with a lead and a battery, a fragile lead and a larger battery and a fatty pocket, the center cathode emits stimulation to the outer anode. So the stimulation dome, it's like a dome on the underneath, lighting up the tibial nerve. It's very forgiving. And the tibial nerve, it's actually quite big. When I do dissections in the lab, I'm always shocked that it's like the size of my pinky. So this will hit the nerve with the way that the procedure was designed. It was designed by an extremity plastic surgeon out of Stanford, Subro Sen. And he said, how can I make sure these pelvic floor people get it right every time?
Right. So how proximate does it have to be? How many millimeters have you got to play with?
Yeah. So the dissection is safely done above the fascia. Yeah. So we do not go below the fascia. I really have no interest in being there personally as a pelvic floor person. I do not want to have anything to do with the tibial vein or artery. And the stimulation field, it's at least 6 millimeters. And then the diameter is about 10 millimeters. And so when you think about the size of that nerve, you're hitting that nerve every time, because it'll take about 4 weeks to heal in for that encapsulation pocket that we get with an IPG in the buttocks. So once it's encapsulated, it's not going to move. While it's healing, micro migrations or migrations up towards the incision doesn't affect efficacy.
So the nerve, just to be clear about the anatomy, the nerve is beneath the fascia, along with all the other important and dangerous structures you want to stay away from. But you don't need to go. You don't need to go. Well, probably best if everyone does, unless absolutely necessary.
Well, if you're orthopedic or an extremity plastic surgeon, they're not nervous. But
never ask an orthopod what constitutes acceptable risk for a patient, or his bank balance. But anyway, so you don't need to go beneath that. You can actually place this device above the fascia without going through that. And that's sufficient proximity to actually get good contact or good stimulation with the tibial nerve. Is that right? In the majority of cases, I guess there's some anatomical variation, but it's not a big factor. Is that right?
No, it's really this beautiful sweet spot that we've always known with PTNS that has these landmarks between the medial malleolus and the Achilles tendon. And there's a custom template marking tool where you use the landmarks to mark out your incision and where that subsequent coin will be in the path of your pocket creation. And so it's a very short learning curve. So that's really exciting because in my opinion, the learning curve for sacral is never ending. Yeah. And sometimes with our training, you don't have to learn anything about sacral neuromodulation. And Some of us as urologists, gynecologists go on to do fellowships dedicated just to this work. So there's not enough of us out there that are extremely well versed in the art of sacral neuromodulation surgery to deliver it on the mass scale, even though it works, absolutely works, and manage it from like a remote reprogramming standpoint for 60% of women that have urge incontinence, or I'm sorry, 50%. I mean, right. So we have this massive amount of patients needing help. We have therapies where only 20% are getting treated. And so I just view everything as we need constant evolution with these therapies, all of them. And we need new tools in the toolbox. And so going back to what this checks, it's something that I think can be delivered by many with, as long as they're taught safely to do it. And the stimulation field is, I hate using the word disruptive, but it's certainly radical from what we've ever known with the lead form factor of how to stimulate the nerve. I love the intermittent peripheral stimulation. So it goes off, once you activate it, it goes off every 3 days for 30 minutes. And then at 18 weeks, every 4 days for 30 minutes. And that intermittent stimulation, I find that you do not get the nerve fatigue, the nerve habituation, that it's, to me, a more stable therapy, because a lot of times with sacral, I have to reset patients, reset their 4 electrodes, because they come in and they lost efficacy where that nerve gets fatigued to that chronic hammer stim. Versus this, anecdotally, I saw less of it, that people stayed constant responders. And number 2, what I really love about this is it's automatic. So the patient has nothing to manage. And in patients that have a lot of medical issues, they're older, they may not be tech savvy, they may have a lot of anxiety, depression. When you say, hey, we're just going to turn this thing on, and you're kind of done in regards to what you have to do. Versus with sacral, we've always had kind of complicated remotes, end user things that the patient has to manage, things they need to recharge on multiple levels, whether it's the IPG, whether it's the external device. And those are constantly evolving. We just came out with something that requires nothing to recharge, which is really exciting. But I feel this checks some boxes that have not been checked before in regards to a patient coming in and you showing them what you have in your toolbox. And I think we may get a higher percentage of patients saying, well, that might work for me, especially if they live a long distance away.
Yes, it's kind of cool because, you know, I often sort of talk about this, the dichotomy between invasive neuromodulation and non-invasive. And I guess the sort of conventional wisdom is that, oh, well, non-invasive neuromodulation is really going to be a much more impactful technology for the population at large, because it just doesn't require the, you said, you know, the same kind of surgical and other sort of burdens around it. However, some of the things you've described suggest that maybe this is kind of, you know, it is still invasive, but it's sort of peripheral, and so it doesn't involve any. I'm sure when sacral nerve surgery goes wrong, then things can really go south in a serious manner. Whereas, or is that not the case? What's the worst thing that can happen with this tibial procedure?
Yeah, I mean, sacral, I think the risks of sacral at this point are relatively low, but you also have some of my bigger issues with sacral surgery. It's not even the sacral surgery, it's the need for general anesthetic in an 85-year-old. They need to stop their blood thinners twice. Things more of that nature. Those of us that do sacral, I mean, it's the same risk of any foreign body implant infection, having to take it out, pain at the generator site, lead migration, having to revise it. The actual like danger of tunneling these things, I think, is relatively low if you stop blood thinners from like a hematoma standpoint. With this device, it absolutely can be implanted in the office with local anesthetic. 85% of the pivotal patients, it was done in the office, just local anesthetic. Patients always like a procedure over surgery. When you say you can have a surgery or you can have a procedure, I found they always say, I'll take the procedure from it just doesn't sound as scary, and that is the truth.
And it's not as scary, right? It's
patients are, and that's only getting worse with COVID. As I went through the 2 years of COVID and tracked my third line therapy penetrations, patients wanted more Botox, more PTNS, just because it was in the office or it's just a procedure. they had a lot more, in my opinion, anxiety and depression, and it was harder to get them to more complicated options, no matter what it was I was treating them with, not just incontinence. And I think that mindset's only going to get stronger in patients. With this risk of you put it in, you get an infection of note the leg, the blood flow is not as good. So it's not as robust as in the buttocks. So you do have to monitor these incisions very carefully. You have to be smarter about patient selection from first an efficacy standpoint. If they have bad neuropathy in that area, well, not a good candidate. If they have bad diabetes, immunocompromised, on steroids, bad blood flow, can't feel their pedal pulses, not a good patient from not just an efficacy standpoint, but from a healing standpoint. They'd be high risk for explant. But if you pick patients that have good leg integrity, the good news is if you were to need an explant, and the explant rate in the trial was 3%, which is well within the norm of FDA neuromodulation safety effectiveness data of 4 to 6%. So they hit that even with a novel therapy. So certainly reasonable, but certainly patient counseling on this. And also if you do have to do an explant, it's above the fascia.
Yeah.
So you're just taking this thing out that's very superficial. You're not getting into something that is below the fascia. So the explants that were done were all uneventful, resolved quickly, but absolutely learning the whole time of how do you reduce infection, because no one wants to have to remove an implant from a patient.
And going back to you mentioned the sort of stimulation protocol, which is amazingly sort of infrequent compared to other processes, and just again, one wonders about what the mechanism here is and how that works. Clearly, it's not constant stimulation; it's delivering some kind of I don't know, stimulating inhibitory neurons or something like that. So how did they kind of work this out, and what are the sort of prospects? Like, do we think there might be a better way of stimulating that could be more efficacious, and what are we doing to explore that?
Yeah, absolutely. So the stimulation paradigm by the company was a guess. I know no one wants to hear that in medicine. Well, we just took our best stab at it.
Right.
It's fascinating because you just take the PTNS needle stimulation. That was a guess as well. And the offering of doing it once weekly, it was, I think most patients would be willing to do that. And then at 12 weeks, we'll do it monthly. So there really wasn't a lot of thought process into it, more just like insurance will pay for it. Well, that's our best guess. And certainly those of us that do a lot of PTNS, we know that the monthly treatment often does not hold patients properly.
Right.
But essentially this device, they took the firmware and they just put in a 20 hertz setting. And then the amplitude setting is based on where the patient feels it, not a comfort. They feel it. They try it for 30 minutes. Would you drive your car, ma'am? Would this wake you up at night? And so I believe you almost run this subsensory, like where they feel it, and you drop it a notch, which potentiates that primary battery life, number one. Number two, can you run this at a lower hertz setting or a different interval setting and still get the same responder rate? And it needs to be explored. There are a lot of animal models looking at tibial stimulation and how it increases capacity. What is the magic hertz where you still get therapy, but you don't overstimulate the nerve? So they hit the target pretty close. But no, this is, sacral's been FDA approved since 1997. This got approval 3 weeks ago. So I'm very excited to see how you can change the stim prescription and also make the average battery life longer and really open up this being a good therapy for a lot of patients.
Have they alighted upon any settings that will actually make the urgent incontinence worse? Even in animals? Really?
So this is a small company. They don't have an animal lab or anything, but I will say one of the big players in neuromodulation does have an animal lab, and they have found that a higher hertz setting actually can make the urgent incontinence worse in the animal model, and actually a more gentle, I love this, a more gentle, and I truly believe this subsensory that it doesn't have to be a motor phenomenon. This is not a motor phenomenon. And I do believe it's like the C delta afferent sensory fibers that are more restorative for this condition. And because when you turn this thing on and you increase the amplitude to where the patient might feel it, they don't get toe flexion, which is always what we've looked for with sacral neuromodulation. You want that bellows at the buttocks down to the toe flexion.
Right.
And this is definitely more of like a sensory phenomenon, and there's obviously a therapeutic effect, but so much to explore. And just they're kind of just getting their toe, they're just dipping their toes in, and they came up with they hit close. And I will say they changed the stim between the feasibility and the pivotal, just learning in that in the feasibility, what I call the maintenance treatment, it was every 2 weeks, not every 4 days, because every 2 weeks sometimes wouldn't hold some of the patients. So they ratcheted it back to every 4 days.
Fascinating. Well, so much more to learn. And as you say, so very interesting as to how the hell this is working. Is it introducing noise? It's inducing plasticity, or so also we'll look forward to seeing what the future developments are with this device and this interesting sounding company, and you yourself, Alex. And thank you so much for giving us such a authoritative overview of this interesting area, and just fantastic to see neuromodulation impacting one of these sort of non-neurological conditions in such a sorely needed way.
Yes, it's an exciting time to take a very unique form factor that, like I said, is very easy to understand and perhaps can be done by many professionals with a short learning curve. So as my mentor, I mentioned him before, Dr. Scott McDermott, he says, do we potentially have neuromodulation for the masses? Like that is his goal. And that's kind of the goal to strive for, because neuromodulation for so long, it's 1% of patients actually getting it due to so many factors. Can we get that number higher with knocking out some of the barriers that have prohibited neuromodulation to being more widely used for these conditions?
Brilliant. Well, it sounds like you're really contributing to that endeavor, Alex, and so thank you again for your time, and we'll look forward to following your activities in the future.
Thank you so much for having me.
Cool.